Varenicline, also called Chantix. By completion of this activity, participants will be able to describe the properties of Varenicline, list the advantages and disadvantages of this drug, describe availability, cost, and coverage, explain standard as well as alternative dosing recommendations, and list common side effects and mitigating strategies. This is the single most effective pharmacotherapy on the market for smoking cessation, but it also has the most reports of harmful side effects. Varenicline works by binding to the nicotine receptor. It's called a partial agonist. It partially stimulates receptor to reduce the symptoms of withdrawal, and it blocks nicotine from binding to the receptor, thus reducing the rewarding aspects of cigarette smoking. So what happens is normally nicotine will bind to a receptor when we smoke. It will release dopamine, and that causes the pleasure of smoking. If we go cold turkey, we don't have any nicotine available, and that causes a decrease in dopamine release, which causes withdrawal and lack of pleasure that comes from smoking. If you use Varenicline, these perpendicular shapes here, L shapes, then it blocks nicotine from binding, but it also partially stimulates the nicotine receptor, so it increases the amount of dopamine that's released. Advantages. It's not metabolized by the liver, so it has few interactions with other drugs. The liver is primarily responsible for metabolizing drugs, and when drugs are used that are metabolized by the liver, it can affect the metabolism of other drugs. But because Varenicline is not metabolized by the liver, it doesn't affect other drugs that are metabolized by the liver. It also may be helpful for patients who are less committed to quitting. We've talked about all of these medications as part of a specific quit date and a plan to quit. One study took patients who were not willing to make a quit attempt in a month, but they were willing to reduce their smoking and make a quit attempt within the next 3 months. The study then compared patients on Varenicline for 24 weeks compared to those on placebo. And there was a higher quit rate at 21 through 24 weeks, more than 3 times as high, and a higher quit rate subsequently up to a year. Again, almost 3 times as high. So even if someone is saying, I don't want to quit now, but I consider quitting in a few months or reducing my use, putting them on this drug as opposed to putting them on nothing triples their chances of being successful quitting at 6 months and at a year. There are drawbacks to how it is metabolized. It's excreted almost entirely by the kidney. So if someone has kidney impairment, then the dose of the drug needs to be reduced. Availability and cost. It's available only with a prescription in the United States, and the cost range is about $2 per pill if it's not covered by insurance. And this is 2 pills a day, so that's $4 a day. Coverage. The Affordable Care Act requires that all Medicaid programs cover all tobacco cessation medications beginning on January 1st. And Varenicline is covered in 49 states. It's not covered in the District of Columbia or West Virginia, and coverage varies by health plan in the states listed. The standard dosing is that smokers are instructed to quit 1 week after starting Varenicline. And this is the time it will take for blood levels to stabilize. This is different from the nicotine replacement therapies we discussed, where the person quits on the day that they start the medication. With Varenicline, you're actually taking the medication while you're smoking for a week. and the dose is increased gradually to reduce the risk of nausea. So you take a 0.5 milligram pill once a day for 3 days, and then you take it twice a day for 4 days for a total of a week, and then you go up to the maintenance dose after week 1, which is 1 milligram twice a day, and you take it for a total of 12 weeks. There are alternative dosing strategies. One is taking it for a longer time before you actually quit. So in one study, the abstinence rates at 12 weeks were higher among those assigned to take Varenicline 4 weeks before the quit date compared with those assigned to take it for 1 week, and that was more than double the quit rate. So it seems to be a reasonable alternative to the 1 week ramp up and then quitting, to actually have the 1 week ramp up and then 3 weeks on the maintenance and then quit. And it also might be effective to continue Varenicline for an additional 12 weeks after successfully quitting, rather than stopping the medication at 12 weeks. In one study, quit rates were compared for those treated for 24 weeks versus 12, and higher quit rates resulted for those treated for that longer period. This was measured at weeks 13 to 24, up to 6 months, and then up to a year. And the rates were 71% versus 50% and 44% versus 37% at up to a year. Side effects and prevention strategies. As I described in the overview, this has the most reports of adverse effects, but it's important to understand the specific studies that were included. We'll first talk about depression and suicide. In 2009, the FDA issued a black box warning about potential neuropsychiatric side effects and advised that patients be told to stop the drug and contact their clinician if they or their family notice any unusual behavior or mood symptoms. And this black box warning was based on an FDA review of case reports over a 12-year period that identified over 3,000 reports of suicidal or self-injurious behavior and or depression. Subsequent literature was performed. In 2013, a study of electronic health records of over 120,000 patients found that there was no increase in the risk of suicide or prescription of antidepressant medication for those treated with Varenicline. In 2015, a systematic review of over 10,000 participants, including many with psychiatric illness, found that Varenicline did not increase the risk of suicide or depression. Again, in 2015, a study in England of over 150,000 participants found no increase in depression, suicide, or self-harm in those treated with Varenicline. In fact, neuropsychiatric events were less common in those on Varenicline compared to nicotine replacement therapy. In 2015, a study of the entire population of Sweden found no increased risk of suicidality or psychosis with Varenicline, but did find an increased risk of anxiety and mood conditions in those with pre-existing psychiatric disorders. And in 2016, a study of over 8,000 smokers, half of whom had stable psychiatric disorders, found no increased risk of suicide or depression. As you can see by the literature, after that initial FDA black box warning, the majority of subsequent trials with large populations found little to no association for Varenicline with neuropsychiatric disorders. So the prevention strategy is to stress the importance of following up with smokers started on Varenicline with a visit or phone call within 1 week. To avoid the drug in smokers with current unstable psychiatric status or a history of recent suicidal ideation. And to possibly avoid this medication in all patients with depression. The second adverse drug effect we'll discuss are adverse cardiovascular events. In 2011, the FDA issued a black box warning that varenicline might increase the risk of adverse cardiovascular events in patients with known cardiovascular disease. This warning was based on findings from a trial of 714 smokers with stable cardiovascular disease, showing that patients treated with varenicline had a higher risk of non-fatal myocardial infarction, although this difference was not significant. And patients treated with varenicline had a lower rate of cardiovascular mortality, though this difference was also not significant. So while people had heart attacks more often, but more than twice as often when they were taking varenicline, they died of these heart attacks, or their all-cause mortality from cardiovascular events was more than half that of people not on varenicline. This is probably because smoking itself contributes to mortality. So the lower risk was associated with quitting smoking. In 2011, a meta-analysis excluding trials with no cardiovascular events found an increased risk of cardiovascular events for smokers on varenicline. However, the methodology may have introduced bias. And in 2012, two large meta-analyses found no increased risk of cardiovascular events in patients treated with varenicline. However, the overall rate of cardiovascular events in the trials was low, limiting the power of the analysis to detect a difference. In 2012, a study of over 35,000 smokers found no increased risk in major cardiovascular events for smokers on varenicline. And in 2015, a study in England of over 150,000 smokers found actually a decreased risk of cardiovascular events in patients prescribed varenicline compared to nicotine replacement therapy. So the majority of studies after the black box warning showed either equivocal or no increase in cardiovascular events for patients with history of cardiovascular events who were started on varenicline. Prevention strategies are to counsel patients to self-monitor for cardiovascular signs and symptoms that are new or worsening, and to get prompt medical care if needed, and then to consider alternative pharmacotherapy in patients with unstable cardiovascular disease. Accidental injury is yet a third potential side effect. A review of adverse drug reports found an unusually high rate of accidental injuries and falls in patients taking varenicline. The FDA subsequently issued a public health advisory stating that patients taking varenicline may experience impairment of their ability to drive or operate heavy machinery. The Federal Aviation Administration has prohibited pilots and air traffic controllers from taking this drug. However, an observational study in Sweden found no association with varenicline and traffic crimes or transport accidents. Prevention strategies for accidental injury: consider an alternative medication for those operating heavy machinery or in occupations where driving is a primary aspect of their profession. Another side effect is nausea, and this is the reason that we titrate. Another effect is nausea, and this is the reason that the dose is slowly increased over the first week. Another way to prevent nausea is to take the drug with food and a full glass of water. Abnormal dreams are another side effect, and they can be prevented by taking the evening dose earlier in the day or eliminating. Abnormal dreams are another side effect of the medication, and they can be minimized by taking the evening dose earlier in the day or skipping it altogether, thereby lowering the entire dose.